Acute pancreatitis is a medical emergency, therefore its degree of severity is important to measure, which is done by different criteria like Ranson's Apache 2, Glasgow, and C reactive protein levels. Higher the severity, higher the mortality. According to Ranson's criteria, we measure 11 parameters of the patient. Out of these 11 parameters, 5 parameters are measured at the time the patient is admitted at the hospital. These 5 include serum glucose, age of the patient, leukocyte count, LDH levels, and AST levels of the patient. These can be remembered through mnemonic call. The pancreatic cell death can lead to decreased insulin and so hyperglycemia. Higher the age of the patient, higher the severity of acute pancreatitis. The cutoff for age is 55 years. As acute pancreatitis leads to inflammation and so WBC count is raised in patient's blood. The death of pancreatic cells causes release of LDH and AST present within the pancreas, and so these are also high. After the patient spends 2 days at the hospital, we measure his further 6 parameters: blood urea nitrogen, his arterial oxygen, base deficit, which means how much metabolic acidosis has occurred within his body, estimated fluid sequestration, which means the accumulation of fluid outside the blood vessels in the form of edema within the pancreatic substance, his serum calcium, and the decrease in his hematocrit. His blood urea nitrogen is raised. This is because when acute pancreatitis occurs, there is a loss of fluid from the vessels due to inflammation, and this causes hypovolemia and decreased renal perfusion. Arterial oxygen also falls. This is because of the inflammation which causes cytokine storm that causes lung damage. Base deficit or metabolic acidosis occurs due to lactic acidosis. Lactic acid accumulate within the cell because there is hypovolemia, and so oxygen and nutrients are not supplied to the cells of the body, which now form lactic acid. Fluid sequestration occurs in the form of edema. Serum calcium also lowers. This happens when saponification occurs and fatty acid combined with calcium present in the blood and lower the serum calcium. Hematocrit is decreased in a patient with acute pancreatitis. This is because in severe cases there is bleeding and hemorrhage within the abdomen due to the action of elastin, and so HB is lowered. These 11 parameters have specific values and cut off levels. Each parameter is assigned a score. After we assess these parameters and add up the score of the patient, we determine how severe his acute pancreatitis is, which tells us his mortality risk. Since acute pancreatitis is a medical emergency, we first resuscitate the patient following ABC guidelines. Since his airway is cleared, we give him oxygen through mask to maintain his breathing. To maintain his circulation, we pass an IV line and give him intravenous fluids. We keep the patient nil per oral. We don't give him any food through his mouth. And in certain cases, if his stomach has any stomach content, we might aspirate it through nasogastric tube. Both these steps prevent aspiration pneumonia. We monitor his vitals, including BP, temperature, partial pressure of oxygen, etc. We also maintain his input and output record to prevent fluid overload. Means we uh, balance how much IV fluid we give him to his output record through the urine catheter. We maintain a central venous line to measure his BP, and we also check his arterial blood gases because there is risk of metabolic acidosis. Analgesics for epigastric pain and nutritional support through NG tube can also be done. Antibiotics are only given in severe cases because after pancreas undergo necrosis, necrotic pancreas can be infected and pancreatic abscess may occur. So prophylactically antibiotics are given. After the patient is resuscitated and he is stable, we perform investigations to find the cause of acute pancreatitis. If it becomes clear and confirmed that gallstones are the reason, then we can perform an emergency ERCP which means ERCP within 72 hours of attack of acute pancreatitis. Through this ERCP technique, we introduce an endoscope through the mouth into the duodenum and into the pancreatic duct and remove and extract the gallstone. After the gallstone is removed and the patient is stabilized and his acute attack subsides, then we can perform cholecystectomy and remove the gallbladder that is filled with stones and is inflamed. If pancreas has proceeded to infective necrosis, means that the necrotic material has been infected, then we can perform two things. We can either perform needle aspiration of the necrotic material, or we can perform necrosectomy. In needle aspiration, needle is introduced through the skin of the abdomen into the pancreas under CT guided technique. CT scans are taken continuously. That helps us locate the position of the necrotic area and the needle that we have inserted. This needle helps aspire the necrotic material. In necrosectomy, which is basically a surgical debridement of the necrotic material of the pancreas, we perform an abdominal incision and approach the pancreas. Then we remove all the necrotic material and close the incision. Necrosectomy has further two types. Necrosectomy is either performed through closed continuous drainage or closure and relaparotomy. In closed continuous drainage, after we open the patient and remove all the necrotic material, we leave behind two drains and close the incision. These two surgical drains help remove any further necrotic material that forms. In closure and relaparotomy, when we remove the necrotic material, we do not leave behind any drains and we close the incision completely. Then after 2 to 3 days, we operate upon the patient again and open the same incision and remove any necrotic material that has been formed over the course of time.